thanks for inviting me to this lovely meeting. It is indeed a shame that I won't be able to join you personally in London, and that goes for giving this lecture as well. This is a first for me to deliver a lecture online, and I feel a bit strange not being able to look the audience in the eye and making the connection. But, you know, it's just the circumstances that dictated, and it was a wise decision to move the conference to an online one. I work in a hospital which is now smack in the middle of the Dutch epidemic. There are over 130 patients with COVID-19 disease admitted to hospital, more than 30 on intensive care, and it's a big, big burden to all the staff involved, both physically and emotionally. And I'm sure that you guys in London are either at the same stage now or facing this public health disaster in a short time. So I wish you good luck. We should stick together and sit this out together and then meet again in London for the next King's Conference next year. And I'd be very, very happy to join you then once again. The title of my talk today is Making Evidence-Based Medicine Work for You, which seems a bit odd because we're all dealing with a new disease for which the evidence is just beginning to accumulate. But then pediatrics is rife with problems for which evidence is limited or lacking. So it may actually be a very timely and relevant subject to talk about. Within the landscape of limited evidence, we still have to make the best possible decision for our patients each and every day. Today, I would like to share with you what I've learned about doing exactly that, using the best available evidence systematically for the benefit of my patients. I will discuss with you how I learned to apply the principles of evidence-based medicine on a regular basis to decide whether the things that I do in daily clinical practice are actually valid and effective. When I started out as a pediatrician many years ago, I had a number of years of experience as a clinical researcher. I had been involved in trials of inhaled steroids in asthma, so I knew about the impressive effectiveness of these drugs, not only from the data of the studies that I was involved in and that I read in the journals, but also from my own personal experience as an asthma patient. And it was my aim as a pediatrician to give my patients the best of three worlds: my clinical expertise as a doctor, the benefits of the best available research evidence, and the integration of those two with the patient's preferences and values. I was, and I still am, very motivated to let my patients benefit from evidence-based medicine as it was intended by the people who started the movement in the early 1990s. And I'm convinced that in itself, this proposition is supported by solid research evidence. Evidence-based medicine has contributed to a large number of major advances in medicine. For example, the use of steroids in pregnant women before they deliver a preterm infant, which is now standard practice. But this has become standard practice only because EBM pulled together a bunch of previously published trials which all had reported non-significant effects. When they pooled all those non-significant studies into a meta-analysis, considerable benefit of steroids was shown. So such examples also help to develop the methods to systematically search, appraise, and synthesize evidence. So during the 1990s and early 2000s, EBM made its way into mainstream medicine, including pediatrics. One of the methodological advances of the EBM movement was this pyramid that you all know, representing the hierarchy of evidence: systematic reviews and evidence-based guidelines at the top, case control studies, case series, and background information at the bottom. These evidence syntheses here at the top, like systematic reviews and evidence-based guidelines, therefore gradually became the gold standard defining optimal care. These systematic reviews and many evidence-based guidelines contain these cool graphs showing us at a glance the validity of the evidence underlying the recommendations in the guideline. This figure, for example, represents the studies examining the use of inhaled corticosteroids in preschool children with recurrent wheeze. As you can see, it's a large volume of evidence, many studies, and overall the validity is very strong. There are very few studies with serious concerns about bias. So this is some pretty reliable, valid, and large volume evidence. And this is then the results slide, the forest plot. You can clearly see at the bottom here that inhaled corticosteroids in preschool children with recurrent wheeze reduce the risk of severe exacerbations and hospitalizations. So if you see this, you would expect that guidelines would support the use of inhaled steroids in preschool children with recurrent wheeze. The interesting thing is some indeed do, but others don't. So it appears that even when the evidence is valid, consistent, and strongly suggests a beneficial effect, experts and doctors making the guidelines can still disagree. They can have different views on the same evidence. Even if the evidence is strong, valid, and consistent, many recommendations in guidelines, in evidence-based guidelines, are colored by expert views, by expert judgments, and by expert opinions. That is one disadvantage of EBM, unless these views and opinions are made explicit and can be discussed, as is the case with recent GRADE guidelines. Another disadvantage of the EBM movement is that the volume of evidence, even the volume of synthesized evidence, has become somewhat unmanageable. This is an example of an evidence-based asthma guideline that you all know. Who of you can honestly say that they read and can reproduce all of the 201 pages of this guideline? And this is the same for most of the evidence-based guidelines that are published today. They're enormous. Even when, as I mentioned earlier, the evidence base for much of what we do in pediatrics remains small and shaky, we suffer from evidence overload in general. PubMed, for example, publishes more than 1,000 new papers each and every day. It's simply impossible to keep up with all the new evidence that gets published. So we rely on these evidence-based guidelines more and more to guide our clinical practice. And this creates a problem. The problem that increasingly we feel the obligation to always follow the guidelines. They are seen as the truth, the one way towards what we should do, a prescription for our actions in a certain clinical scenario. So it seems that guidelines have become like trend lines. They do not just guide us through the evidence and recommend a course of action based on the best available evidence, a recommendation that we can choose to disregard if our clinical expertise or the patient's context, values, or preferences suggest an alternative course of action to us. No, increasingly, guidelines prescribe an itinerary that we have to take. In a recent study among specialist registrars in the Netherlands, we found that these young doctors felt a very strong responsibility to always come up with the correct diagnosis and then to prescribe to their patients the best therapy for their diagnosis based on the evidence-based guidelines that were available. So it has become their professional identity to always follow the guidelines. Guidelines have also been abused as a financial incentive to promote so-called quality care. Only doctors following guidelines would be reimbursed for their work. So where is the patient in all this? Has the patient been reduced to a diagnosis with a tramline treatment? That's what the registrars in our study suggested, although they did realize that this approach became problematic in patients with multimorbidity. There are different guidelines for each of the patient's diagnosis, each with different recommendations, and sometimes these recommendations are contradictory. So in a sense, EBM has become a victim of its own success. The movement focused so much on research methodology and evidence synthesis that the individual doctor and the individual patients got increasingly neglected in the process. It isn't very surprising, therefore, that many doctors view EBM as a straitjacket, as cookbook medicine, or as an academic exercise that does not reflect how they practice. Two leading figures in the EBM movement have put this into words very nicely. This is a quote from Paul Glasziou, an Australian general practitioner and a researcher in evidence-based medicine. He says EBM is a bit like safe sex. People talk about it a lot, they preach and teach it a little bit, and they practice it infrequently. And Trish Greenhall, the former editor of the BMJ and a professor in primary care medicine in London, even described EBM as a movement in crisis a couple of years ago. What these authors have seen happening, as have I, is that the original concept of EBM, an integration of the best available research evidence with clinical expertise and the patient preferences and values, is being interpreted increasingly by doctors as a blend of their own clinical experience, their own clinical expertise, sprinkled with a cherry-picked selection of the evidence which they pick up by going to conferences and continuous professional development workshops, by reading selected articles in scientific journals, and by talking to their colleagues. And that most of the EBM community, the people who research and promote EBM, have gotten stuck with only one approach, only with finding, appraising, and synthesizing the evidence. And they seem to have lost touch with the clinical community of practicing doctors. This is sad in a way, because the founding fathers of EBM, like the great David Sackett here on the slide, always emphasized the key importance of integrating this best research evidence with clinical expertise and with patient preferences and values. So where does this leave us? How can we learn to practice EBM as it was intended? How can we avoid to get stuck in the evidence-only trap? What do we know about the effectiveness of teaching evidence-based medicine? How can we actually make use of the best research evidence for each patient who comes to our clinics? Well, we do try. Almost every medical faculty in the world offers some kind of EBM training, and the effects of many of these educational efforts have been studied. The results, however, are not always very encouraging. One reason for the limited success of the EBM training in preclinical and clinical medical education is that medical students and registrars are exposed on a daily basis to poor role models in the use of EBM. Their teachers and clinical supervisors do not practice EBM, as we saw earlier. If these real doctors do not give the good example, how can we expect the young generation to start practicing EBM? Secondly, despite the training they received, most final year medical students and registrars have poor EBM skills. Even if they understand and can reproduce EBM principles, they struggle to apply them. And they know this too. They feel very poorly prepared to actually practice evidence-based medicine in their daily work. So here is what we know. Our current approach to teach students and junior doctors about EBM, usually in standalone workshops, it improves their knowledge and skills a little bit for a little while. But this fades away quickly, and there is no effect on long-term skills, no effect on their attitudes towards EBM, which remains skeptical, because that is the attitude that they see in their role models, and they do not show EBM behavior in practice. What we also know from syntheses of all the evidence on the effects of EBM training is that such training can be effective. It becomes more effective when we integrate it with clinical activities and with the daily routines of the team. If the teaching team, the clinical team supervising medical students and registrars in clinical medicine, if they truly value EBM and they lead by example, the junior doctors are much more likely to follow. This then was the guiding principle on which we designed and started our EBM project at the pediatric department of my hospital in the Netherlands over 10 years ago. And we published the long-term results of this project in BMJ Evidence-Based Medicine 2 years ago. I'm happy to share the PDF of the presentation with you if you send me an email, and of the article. The aim of our project was to improve patient care, obviously. And we wanted to do this by reducing practice variation between doctors, between pediatricians, because we argued that practice variation is only okay if it serves the patient's needs, but not if it serves the doctor's prejudices. And we wanted to identify the diagnostic procedures and therapies that were ineffective so we could stop doing them. So what we did was that we worked on developing compact local guidelines. Sometimes these local guidelines were summaries of national or international evidence-based guidelines tailored to our local situation and avoiding the excessive volume of the international evidence-based guidelines. For other problems, there were no published guidelines available. We would collect, appraise, and synthesize the best available research evidence ourselves in a systematic way and develop our own guidelines. We aimed at developing the guidelines for the 25 most common problems in our practice and at keeping these guidelines up to date. We did this, keeping the guidelines up to date, by using alerts to find new evidence that became available after publishing the guidelines, and by systematic reflecting on our clinical experience in using the guidelines in practice. I will come back to that in a minute. We also agreed that we should all follow these local guidelines. Once we agreed upon them, we also expressed the intent to always follow the guidelines, and that we should justify, both in the patient chart and to each other, when we deviated from them because of our clinical expertise and the patient's values and preferences. This was our pediatric consultant team at the time when we started the project. And we put this principle of wanting to be an evidence-based practice in our department's mission and vision. This also meant that when we recruited new consultants, we only employed them if they explicitly agreed with the mission and vision of being an evidence-based practice. The two ladies here, Jolita Beckhoff and Vera Langenhorst, were the leaders of the project. They went to Oxford to follow courses on teaching evidence-based medicine, because we decided that we wanted to be trained in the basic principles of EBM, and we should send out people to a center of evidence-based medicine where they could learn how to teach other people these principles. So they designed their own EBM course, and we were the first candidates to follow the course. The course has now been in action for more than 10 years, and we've trained hundreds of physicians from all over the Netherlands. A highly interactive 2-day course in the principles of EBM. In the slide, you see an exercise where we practice with measuring head circumference as an exercise to appreciate the problem of inter-observer variation in so-called objective measurements. After following the course, half of our team became teachers in this course. This is important because educational research shows that people learn most from teaching themselves. Each new consultant on the team that we recruit is also required to do the course within 1 year of becoming a team member. So we keep the knowledge in the team up to date and the skills on EBM. The second thing we did is that we included several EBM activities into our weekly schedule of meetings and team activities. Every week, we have a journal club, a PICO or critically appraised topic meeting, and a guideline review. The guideline review is a meeting in which we discuss pitfalls and problems in our guidelines that we encounter when applying the guideline in the care of patients. So, for example, during morning handover, we will present, having seen a patient for which we have a guideline, something in the guideline was either unclear or difficult to apply, and we will discuss it and see how we can amend the guideline to make this more clearer and avoid the ambiguity. This way of reviewing our guidelines based on our own clinical experience helps keeping our guidelines applicable and up to date. I will now tell you a little bit more about the journal club and the PICO-CAT meetings that we started. In my experience, and you may have the same experience, the traditional approach to journal clubs tends to be a bit boring, with the junior doctor going through a paper from introduction to discussion and the rest of the team dozing off or checking their email. So we decided we wanted to make these journal clubs more juicy, more engaging, more active, and more effective. We do this by having election days twice a year in which we select and elect very democratically and transparently the papers that we are going to review at Journal Club in the months to follow. The second novelty in our Journal Club was that we included the VAR. And in evidence-based medicine, the acronym VAR stands for validity, applicability, and relevance of the study, of the evidence. These are the 3 key steps in judging a paper's value, the VAR. First, you always need to assess whether you can trust the results of a study, i.e., were the methods of the study valid. There are published Cochrane collaboration criteria to do this, to judge a paper's validity. And by applying these validity criteria systematically to each paper that we review, we've come across many methodological flaws in published papers, even if they appear in high-impact journals. For example, a study on fluid restriction as treatment for transient tachypnea in newborns, advertised as a randomized trial in a major pediatric journal, turned out to be a non-randomized study with an unclearly defined primary endpoint. This was a study invalid by design. So in that case, you cannot trust the results and you should discard it. Even if the methods are valid, which is commonly the case, of course, we still need to consider whether the findings of the studies are applicable in your own setting. Another example. We argued that studies on minimal traumatic brain injury in children from the USA would not be applicable in the Netherlands because the traffic situation and hence the nature of skull trauma in children old enough to participate in traffic would be completely different between the 2 countries. This prompted us to deviate deliberately and consciously from an evidence-based international guideline, which was based on the US data on CT scanning in minimal traumatic brain injury. And it prompted us to start a study on predictors of serious brain injury ourselves. And in this study, we found that children who came into the emergency room with a high and complete Glasgow Coma Scale score were so unlikely to have serious intracranial injury that a CT scan was not indicated. We've now followed up these children and showed that this prediction rule that we developed is valid and safe. Thirdly, after you consider the validity and applicability of a study, you always need to consider its relevance. A statistically significant outcome, a statistically significant difference does not always equate to a clinically relevant effect. Another example. Studies on palivizumab in preterm infants show a 50% reduction in pediatric hospitalization rates, which looks quite impressive. It's also highly significant. However, if you calculate the number needed to treat, it shows that you have to treat 20 patients with palivizumab to prevent one hospitalization for a preterm infant. And if you take into account that each palivizumab course costs about £5,000 per patient, you get a very different perspective on the relevance of this effect size. The judgment of whether this benefit justifies the financial cost and the side effects is personal, of course. Having a discussion about treatment effect like this in a pediatric team based on solid and relevant data is absolutely worth the effort, we found. So these journal clubs that we have are active. All the participants are asked to review the methods section of the study to judge the study's validity, and they are being engaged actively in a discussion about applicability and relevance of the data. The person preparing the session only moderates it. There's no presentation. We don't use PowerPoint. We want the audience actively involved, each and every one of them, including the consultants. The weekly PICO or CAT is a short presentation after morning handover with a consistent structure that always begins with a clinical question raised during an encounter with the patient. For example, we wondered how useful is the use of fecal parasite testing in children with abdominal pain. That's a question that you can frame as a PICO. Or how useful is cohorting of children with bronchiolitis caused by different viruses in predicting their outcome. The person preparing the PICO then described how he or she searched the literature systematically to find all the relevant evidence. We discussed the validity, applicability, and relevance of the evidence. The person preparing it then comes to a conclusion with a discussion of the implications for our own practice. So, like the journal club, PICOs are prepared both by registrars and by consultants, keeping everyone active, practice by doing, because that approach is supported by educational research evidence and because it makes us, the consultants, lead by example, to be a role model in not only knowing about EBM, but also applying it. We evaluated the results of the PICO system after 8 years. After those years, we had collected more than 500 PICOs, all available on our internal online system. Approximately 1 in 3 PICOs produced valid, applicable, and relevant evidence. And about 1 in 5 actually led to a change in our local department guideline and policy. And another 1 in 8 led to new research questions that we would address ourselves. A couple of examples. One example was the use of fecal parasite testing in children with abdominal pain. The PICO was very clear. There was good and reliable evidence that showed no different outcomes in children being tested and treated for fecal parasites and those children who were not tested or treated for fecal parasites in determining their outcome of abdominal pain. So we stopped doing this diagnostic procedure in children referred for recurrent abdominal pain. A thing that we studied ourselves was the effect of cohorting for children with bronchiolitis caused by different viruses, because there was absence of evidence in the literature. We recently published the results of this long-term prospective cohort study showing no different outcomes in children cohorted or not cohorted by different viruses. So this means probably that we can, and that we've done that we can stop cohorting these children. And that means that we can also stop doing the viral testing in bronchiolitis season, which saves a lot of money. Although this may become different once we figure out the role of coronavirus in bronchiolitis. A third example is the use of fluid balances in newborns. That was the standard operating procedure in our newborn department, that sick newborns would have a fluid balance every day. But once we did the PICO, we found absence of evidence. So we studied it ourselves and we published the studies showing first that keeping fluid balances is highly unreliable. And then in a randomized trial that keeping a fluid balance does not affect the outcome of these children. So we stopped doing it. As I told you, we started out this project with the aim of producing local guidelines for the 25 most common problems on our ward in our outpatient clinics. But after 10 years, we had almost 180. The development of these guidelines and their further development over time, based on guideline review discussions and on PICOs, those were the expected outcomes of the project. But there were also unexpected outcomes, collateral benefits of the project. The most interesting one was that we found over time that our department culture changed. It changed from a culture of Hermione Granger type people who always know the answers, a culture of expertise in which the consultants were expected to be sure of themselves, have the expertise, and make no mistakes. And it changed to a culture in which it became increasingly okay to admit that you were unsure, to ask questions, to acknowledge doubt. Asking a question or acknowledging that you do not know is a prerequisite for lifelong learning. We can only get better if we are willing to face and acknowledge our uncertainties. This gradually became more and more normal in our unit, and all of us consultants agreed that that was a good thing. Medical students and registrars passing through our department also noticed it. They felt it very liberating that they were welcome to ask us questions, to challenge our assumptions, and that we would freely discuss our uncertainties and our differences of opinion regarding the optimal care of patients. This changing culture also taught us the importance of systematically reviewing our errors. So we now added a fourth meeting to our weekly schedule, which is a weekly discussion of the errors and the mistakes that we made in practice. Last year at King's Conference, I presented one of those serious mistakes that I made myself and what we could learn from it by discussing it openly within the team and with the learners in our department. So this uniform acceptance of safe communication and shared learning has been found to be one of the strongest drivers of effective learning of EBM skills in educational research, and it's certainly helped us. So we showed that it is possible to teach busy clinicians how to apply and practice EBM in their daily work. to change their behavior from a culture of expertise to a culture of learning and growth. And we showed that this has beneficial effects both on patient care and on the learning environment of our medical students and junior doctors. So in conclusion, it takes deliberate practice to learn and to continue to apply EBM skills in your daily work. So I would recommend that once you have followed a course on the principles of evidence-based medicine, which I recommend for you, that you should then try to integrate the tasks and skills that you learned into your weekly department routine. And to base all these activities on real questions from real patients, make it a team effort, and embrace failure and uncertainties as catalysts for learning. This is really a win-win for everyone. I very much enjoyed both the journey and the destination. I hope that this may inspire you to try and make the EBM journey yourself as well. To practice EBM as it was intended by the astute clinicians who started the movement to let patients benefit from the integration of clinical expertise, the best available research evidence, and their own views and preferences. Thank you very much for your attention, ladies and gentlemen.
Thank you very much, Paul, for the excellent talk. Please type in your questions or any queries if you have about this presentation. So Paul, Jamila, based on the applicability, which is more relevant, clinical significance or statistical significance?
You can't do either without the other. If you think that a result of a study is clinically relevant, so the effect size is large, but the effect is statistically non-significant, you have to consider the possibility that the large effect is due to chance. So what you then would need is additional studies with larger samples. With each study with a statistically significant result, you should always ask yourself, okay, this result is significant, so it's unlikely due to chance, but so what? Do I care? Does this effect size make me change the way I want to practice? And we found that by doing this over and over and over again, it became very interesting to start, before you start reading a study in detail, that you think about, okay, in a study on fluid restriction in transient tachypnea in the newborn, for example, what effect size would I find relevant to make me change my practice if that effect size was actually found? So define a priori the effect size that you feel is important. I can't hear you, Atul. You should switch on your microphone.
Yeah, thanks, Paul.
You're welcome.
Emily, what did you find the most challenging part of the changes you made to the department?
Oh, two things actually. The first one was to get the project started and to have everyone agree that we should reduce practice variation. That took a lot of group discussion, but once we established that, getting the project underway was not the big issue. The second main challenge was to keep it running when we were out of the pioneer phase. Everyone is excited about pioneering something very new and exciting, but once we were past that phase, to keep everyone involved and motivated was a bit of a challenge. And we tackled that by making sure that everyone was scheduled to prepare presentations and PICOs and journal clubs throughout the year. So there was no escaping.
Thank you, Paul. apart from the courses, are there any other resources you could recommend for the junior doctors to improve EBM skills?
Well, as a junior doctor, you are left with, well, you are a part of the team that you train in, but you're not in a position to easily change the team's weekly routines. What you can do, and what I recommend you do, is that after you've followed an EBM course, you make sure that you get your practice. And you can do that by entering into your weekly routine with your colleagues, the routine of journal clubs, PICO cats, and guideline reviews, and show then to your supervisors that you're enthusiastic about this and that this is worthwhile for you.
Thank you, Paul. Victoria, thank you, Paul. Would you encourage patients and parents to engage with EBM? And should we be including them more where appropriate?
Yes, I would, because I found that if you are confident in knowing your research, and if you are confident in being able to present the effect sizes of research that you have considered to be valid and applicable, and you present this in a quantitative fashion to parents, that helps them enormously in making the best decision for their child. For example, we showed in our clinic that of all the children with chronic asthma, more than 90% became fully controlled once we started them on daily inhaled corticosteroids. And we've used this as a statement that we can tell parents with confidence. So yes, we understand that it's bad news to hear that your child has a chronic disease, and it's bad news that in order to change this, you would have to give your child medication on a daily basis. But we can say with confidence, based on evidence, that 9 out of 10 children who we treat with this drug will be fully free and fully controlled, and fully free from symptoms, and can engage in sports and play and all the activities that they want with very, very limited side effects. So yes, giving parents numerical information about the effect size based on evidence, in my experience, clearly helps in aligning them with your decision that you feel is most appropriate for your patient.
Thank you, Paul. Couple more questions. Thanks for the excellent talk. Abraham, how long does a PICO take to complete? And did you allow a lot of time for the staff in your busy schedule?
Yeah, we also recorded the self-reported time that people spent on preparing PICOs, and exercise helps. So once you do a first PICO, it takes between 6 and 8 hours. But after you've done 3 or 4, that comes down to about 1 to 2 hours for a PICO. And yes, you can do that in a busy practice if you spread the tasks among the entire team, which we did. So the preparation time is the same for everyone. The preparation time is spread out evenly among everyone. And having these journal clubs once every 14 days and having these PICOs once every week is a limited time investment to keep these important skills active and trained within the entire team.
Thank you. I think you've answered this one already. Should there be a different approach in different sizes of teams?
Well, I think the principles could be very much the same. It all begins with making sure that the entire team agrees that this is an important avenue to pursue, and then decide with the team how you want to make this work. And that can change between teams, of course. But I think the basic principle is make sure it's in your mission of the team, make sure you all get the training, and make sure you all keep practicing it.
Thank you. Last two, Paul. How do you ensure that you have set time for this?
We ensured it by just putting it into our weekly schedule. We all have our weekly schedules with our scheduled meetings. Morning handover is a perfect example. Morning in the Netherlands, morning handover is a mandatory teaching exercise for every teaching department. So we connected these meetings, these PICO and guideline reviews meetings, to our morning handover. So we would have morning handover, and immediately afterwards, before each and every one went to their outpatient clinics or ward duties, we would have the PICO meeting or the guideline review. And we would have the journal club over lunch once every 14 days.
Brilliant. Thank you. And the last one, Paul. Did the people use PICO within their own specialties, especially if you're working in a big regional center? There are lots of specialties there, or did you encourage them to go outside of their specialism?
Both. The key was that it always should be based on a patient that you saw in clinic. For example, I've been wondering about kids with asthma and allergies, for example. Okay, how useful are antihistamines in the treatment of itch in children with atopic dermatitis? There's actually very, very limited evidence for their efficacy, by the way. But I also considered that the question about fecal parasite testing in abdominal pain was one that came from me as well, because every now and then during even if you're highly specialized, you will meet a patient with a general pediatric problem in your clinic or during your on-call service. So I would recommend looking beyond the narrow margins of your own subspecialty to keep this active.
Thank you very much, Paul. And sorry again, we can't meet face to face, but hopefully next April we'll be able to catch up for this year as well.
Absolutely, will do. It was a pleasure to be here, Atul.
Thank you. Stay safe.
You too.
Thank you.
Bye-bye.
I think we are 3 minutes.